Jorge and I have been looking at something. It's work in progress, but we want to share it with you. Just to kind of lighten the mood up a bit, I just want to kind of do a little exercise with you. What you see is a bulb, yeah? It's 6-volt bulb. Can you predict how many batteries, normal batteries, 1.5 volt, you need to light this bulb up? How many? 4, I heard. Okay. Correct. Okay. So you have 4 batteries. They are adding up, connected in series, and the light bulb is switched on. What's happened here? Light bulb is turned off. What's happened? It's only 3 batteries, isn't it? It's not going to switch on. What's happened here? They're now working together. That's correct. So lots of things actually could have happened. So batteries, they're not adding up. The light bulb is still turned off. Or the batteries are not charged enough. Yeah? They're not producing 1.5 volt. So the light bulb is not on. Okay? I want you to hold on to that thought, but we'll go to our slides. So our aim is to create a tool that will help us to reduce self-harm and reduce violence on inpatient wards. Okay? So we want to have wards which are high in therapy, low in conflict. How we're going to do that? What we want to do is we want to increase staff awareness about the risks and the protective factors. Okay? Not new really. But what we also want to do is increase patient awareness about the risks and the protective factors. And what we then want to do is we want to be able to anticipate, we want to predict what's going to happen if so many risk factors add up together, and what do we need to mitigate that risk so that there are no incidents. Okay? So we are moving, we're coming forward. We're not going to restrain. We want to prevent restraint, but we want to think before anything can happen, before incidents happen. So incidents in acute psychiatry, I work on the other side. So I kind of look at 2 sides. I run an acute assessment unit. I also am consultant for PICU. So I look at both sides. Most of our patients, most of the patients on our wards who stay longer, they are the ones who don't want to be there. They are detained under Mental Health Act. They are the ones who have, who are worried, who want to go, who depend on us. And they are the ones who have negative perceptions about the inpatient admission. Those are the patients we want to work with. So those patients, when they are on our wards, obviously it becomes a workplace hazard. So we have nursing staff who get assaulted. 25% of the nurses experience a violent incident. Think about the economic cost. This was, the figures are from a study in 2007 of inpatient sports in England. Over 72 million conflict behaviors. That was the money that was needed, the time that staff spent on these incidents. And then more than 100 million on containment. This is the observation that you have to put someone on one-to-one or intermittent observations. And what happens with these incidents is that those patients who have negative perceptions about the whole admission, when they are involved in an incident or if they experience an incident, that reinforces that negativity. Staff who are involved in dealing with incidents, high anxiety, high sickness, and all this leads to poor patient care. And that's what we want to change. There's a lot of research around. What are the things that lead to incidents on wards? We heard from our qualitative study what's coming out. It's not surprising because these things have been researched quite a lot. So we have internal factors related to the patient, whether that's age, gender, psychopathology, substance misuse, all those factors. We have external factors linked to the environment, what type of ward they are in. We heard about the bedroom, how much lighting there is, how much noise there is. What about other patients who are on the ward, how they are making patients feel. We have situational factors, and I think that's very important. That is the interaction between us and the patient. That is the opportunity where we can make some difference. And that's what's coming out through the research as well. And then we have system factors. That's the NHS. What are the ward policies? How this door should be locked? How food should be served at this time and there should be no smoking breaks? All those things play a part in what we see. And then what we have is our risk management tools, risk prevention tools. We don't have any prevention tools, we have kind of management tools. So we have RIO. We know there are lots of tools around and we know how they work. The problem with a lot of these tools is that we actually know what the risk factors are. They're all there. What we are lacking is the most important input, which is the patient input into these tools. We don't really know. So I have a patient who has got serious mental illness. He has got previous history of violence. He's detained under Mental Health Act. He's on a PICU, and he doesn't want to have a depot. Okay, what do I learn from this? What does it mean for that patient on that morning when he's going to have a depot? Okay, and I think that's what's important. What do I learn from that? And I think as Manan was kind of talking about his experience, thinking about the other world, thinking from the patient side, and I think that's what we're lacking. Okay, I'll come back in the end, but I'll pass you on to Jorge.
So one of the things to start with was to ask the question, what did people do in other places? Unfortunately, someone's done the research. This is a study looking at 32 hospitals in England. And that's just after an incident of self-harm. What did they use? Do they have any tools? Do they use clinical judgment? And really the point that people are trying to decide here is, this is A&E or this is an inpatient hospital. The patient has self-harmed, and the decision to be made is, do we send this patient home? What do we do next with this patient? But typically, this scenario is quite common in A&E. And what the study shows is that 20% just use clinical judgment, and about half and half, 37% and 40%, 37% use published risk scales, and you probably can't read but it doesn't matter. There's the SAD person scale, which is the most common one, which, as Zahoor mentioned, is just a list of risk factors. So if you score highly on that list, then you might want to call a psychiatrist, or you might want to consider an admission for the patient. And that works, but it only works in that scenario, and it doesn't work really well. And the other 40%, the long list below, is just things that they have come up in the trust. They haven't been validated, and but it's still to answer that same question. So can it be done differently? And that's the proposed format at the moment, coming from some of the work that Kerry has done about the environment, about communication, staff and family. So the things on the left, you have the factors influencing the risk of self-harm. And I'm talking about self-harm, but it could be violence, it could be anything else. So there will be patient issues, staff or family issues, and environment. And then there's what we are all familiar with: predisposing, precipitating, perpetuating, and protective factors. And in brackets underneath is just language that you use to make it a little bit more understandable to someone who's not in mental health. And what it is you grab this tool and you have a conversation with a patient. And it's a structured conversation, and you try to focus on the things that are modifiable, like things that you can change. If they have a history of violence or a history of self-harm, that will predict self-harm more than anything else. But having a history that never changes. So you try to focus on the things that you can change. And you come up with a formulation. And the point of this is that you use this tool as the patient is, if it's in an inpatient setting, during their stay, you're using this tool constantly. And you're sharing it with the staff, and you're sharing it with the carers. And one thing we're thinking about is for people that might have difficulty in expressing what their risk factors are, at the back of the tool there will be a list of possible things that they would like to consider just to facilitate the conversation. I'll give you an example just to illustrate from Springbank, which is, for those of you who don't know, a ward for people with borderline personality disorder, women, with quite often severe self-harm. So one of our patients, after a train ride from home, she was on leave and she came back from home, had a drink, and then self-harmed. And we just used this incident as a starting point for the conversation. And this is what we came up with. So this was just with an A4 piece of paper, and then it was typed up. But she identified that one of the predisposing factors for her is that cutting distracts her, makes her feel relaxed, and gives her some relief. Things that predispose, the family not being tidy, she went home, it was not tidy, that really bothered her. And the fact that she really likes things clean, so coming in and out of the ward constantly makes it harder for her to clean home, so when she goes back home, she spends all the time cleaning, and she has arguments with her family. Things that are triggers to her are stress, feeling emotional, alcohol, her daughter's arguing, husband shouting, and in terms of the environment, noise. She kept mentioning noise. Very busy, cramped environments, and being home alone. Which, being home alone, she identified as a precipitating factor, but also as a protective factor. And things like gaining weight, she's gaining weight currently, not having good sleep, perpetuate this problem. And so there are a number of protective factors which she identified as losing weight, running, being around with her family and friends, and sometimes being home alone to be allowed to clean. That helps her bring her anxiety down, and especially low noise levels and not any crowded places. So after we finished this, I typed it up and gave her a big side of A3, and then she's working on this. And it was unfortunate, but the idea is that once you have this and you share it with staff, and at this point we hadn't shared it with the staff, the staff will have a better idea of what she is like and what triggers her. And what happened, and this happened after the presentation was completed, was that she was in the shower on the ward, and for some reason the steam of the shower triggered the alarm. And again, noise was something that triggered her, and within a few minutes she was self-harming again. So those are if you know about that, those are the instances when you can act early. If you know that, for example, that alarm would have been very meaningful for her, or would have stressed her a lot, staff could have been there with her.
Thank you, Jorge. That was quite serious. So let's go back to batteries. So when the light bulb turns on, that's an incident. Okay? We know the batteries. We know the risk factors. What we don't know is, do they connect properly? And what's the charge in each battery? The concept is to sit with patient, list those things which will trigger an incident, which will fill these batteries, and which will switch on the light bulb. That will be an incident. So our job is then to make a list of other things which will be mitigating factors. Also make things which will kind of help us to disconnect the batteries, sitting with the patient, have a list. And so if the charge is rising, the bulb might turn on, you put something in, the light bulb is not going to switch on. So that's the kind of concept. What we want to do is we want to develop it into an app so that the patients and the staff can together work on it. They have the risk factors and the mitigating factors at the bottom. They're filling the batteries, but at the same time, they're managing it because they're taking other things that can put in the batteries and discharge them so that they don't produce the current that's needed to light the bulb, which is the incident. Okay, that's from us.